to you, Chair.
Thank you. Good afternoon and welcome to Kirklees Health and Wellbeing Board, held on the 25th of March 2021. Can I start by opening the meeting and welcoming board members and attendees, and remind people that this meeting is not only recorded but also webcast live. If during the meeting you wish to speak, please use the chat bar and not the raised hands. It makes it an awful lot easier. And please, could we only use the chat bar to say when you wish to speak? I'm being asked to put my camera on, but my camera is showing as being on. Attendees are asked to switch their cameras off until it's time to present their item, but board members, will you keep your cameras on, please? And I'm trying to keep my camera on, but apparently it's not showing. I'll continue on. Can we start with agenda item 1? So this is for apologies and membership of the board. So Jenny, have we any apologies for the meeting?
We have apologies from Councillor Khan, Councillor Patterson and Councillor Pinnock.
And I understand Helen Hunter has sent
And Helen
apologies.
Hunter has given her apologies.
Yeah. Thank you. And membership of the board. Phil, you're going to take us through this, please.
Yeah, hopefully I'll get everybody who's in attendance. So we've got Councillor Mark Thompson from the CCG. There's Carol McKenna, Beth Hewitt, who's a new member, who's the lay representative on the CCG board, and now on the Health and Wellbeing board. Dr. Steve Ollerton. From the council, there's Richard Parry, who's Director of Adult Social Services, Rachel Spencer-Henschel, who's Director of Public Health, Mel Meggs, who's Director of Children's Services. In attendance, we've also got representatives from Caldale Huddersfield Foundation Trust, Catherine Riley, Mid Yorkshire Hospitals Trust, Tilly Poole. From Locala, there's Diane McKerricker, the chair of their board. And from Swift, there's Rob Webster. We've also got Karen Jackson, who's representing the Kirklees Integrated Provider Board. And I think I've got everybody, but please do in the chat let me know if I've missed anybody.
Okay, thank you very much. Just before we move off this membership of the board, I had a very nice email around about lunchtime today from Dr. Steve Ollerton, who was reminding me, I think, that this is his last meeting of the Health and Wellbeing Board. He said some very nice things, which I'm really pleased about, but I have to respond back in saying, you know, I've enjoyed working with you, Steve. I think you made huge contributions to the board, huge contributions in your leadership, and your buoyant personality always pleases me, which is an added bonus as such. Hopefully, as you say in your message, we're going to be working together in the future through the ICS. But I'd just like to take this moment to thank you very much for all your contributions to the Health and Wellbeing Board. So thank you. So can we move on? Can we move on to item 3, please? Item 2, rather, the minutes of the previous meeting. Just if anybody could indicate to me if they feel that there are any inaccuracies or any corrections that need doing, if you put something in the chat bar. But if not, I'm assuming that they are a correct representation. And I'm going to take it that everybody is in agreement that they are correct, unless you signal to me that you feel that's not so. It's very difficult to take a vote in these circumstances. Okay, thank you. Interest, can I remind board members that if there are any disclosable pecuniary interest, they need to declare them, and they need to therefore not take part in any vote on anything. But I don't think there's anything of specific nature to vote on, but in the pack on page 9 there is a form that can be completed if you need to declare an interest. All the items of this meeting are to be held in public, so there is nothing specific we need to do about admission of the public. It is being webcast and it is being recorded. So we move on to item 5, please, deputations and petitions. Jenny, have we any deputations or petitions?
None received, Chair.
Thank you very much. Then we will swiftly move on to item 6, which is a COVID-19 update, and we are to receive a verbal update from Rachel Spencer-Henschel. Rachel, over to you.
Thank you so much, Chair. If it's okay, I'm going to share my screen. So if someone can just let me know when you can see the slides.
I can see the slides.
Excellent. So what I've got for you today is just an update on the case numbers. This is accurate as of today. We have seen a slight increase in the cases over the last week, and we are currently 16th out of 149 local authorities, and our rate is 107 cases per 100,000 population. As you can see, where we feature across West Yorkshire is that Bradford and Wakefield are currently in the top 10. But if you can see from that graph where we are, our cases, we're in the blue, are slightly increasing, which compares to the yellowy orange line, which is the England average, which is still reducing. So obviously that shows that in Kirklees, although our rates are significantly lower than they were, and we have seen progress in terms of those rates reducing, that reduction has slowed and started to slightly increase. Now, obviously, with the schools returning, that's going to have an impact on our cases because of the implementation of lateral flow testing within schools, because what that does is it will highlight individuals that have it and have no symptoms. So it's proactively identifying cases, which is obviously really important in terms of breaking the transmission chain, but it does obviously then show that we have more cases and impacts on our rates. This is just a ward breakdown, and it's quite challenging, I think, when you look at some of the ward breakdown. So on our website, you'll be aware that we have this data there for you to interact with, and it goes down to middle super output area, so even smaller than ward, but it does give you information about the cases and the distribution across our district. And what we do see is that there are pockets of cases, particularly in some areas in North Kirklees and North Huddersfield, that do reflect where we've seen more endemic transmission throughout the whole of the year. And when I come on to the next item around inequalities, I can talk a little bit more about the impact of COVID on that. The next slide is just to sort of show you that breakdown within those middle super output areas. I guess it's important to say at this point that because we are down to quite small numbers, it's easy to see where we've seen a bit of an increase, and sometimes that can be to do with an outbreak within a workplace that we're experiencing, or just something that detects a higher than normal number of cases. And what we do is we have a local contact tracing system where we can go out and try and make sure that those cases that the national team have not managed to contact, that we can visit them and make sure that they've got everything they need to be able to self-isolate. So we keep a track on this, and obviously with our partners, we work in communities to try and understand what's causing those increasing numbers and making sure we're getting the key hands, face, space messages out. Just a reflection on testing rates and positivity. So on the left is the PCR test, which is the ones that you get if you have symptoms. And then on the right is through our community testing sites, which is our lateral flow devices. So as you can see, the positivity has dropped off quite dramatically to where they were at the beginning of February, which is generally reflective of the levels of infection within the general population, but it's really important to keep an eye on that. The testing numbers for lateral flow have increased, as I've said, because of obviously the testing of school and college age pupils and teachers, because obviously quite a number of them are making use of our testing sites. So again, good that the positivity is coming down, and good that people can still access testing, because that's obviously still important to make sure that people with symptoms can get tested, but equally something to keep an eye on. I'll just finish sharing my slides. It's probably also worth saying that obviously there is a change to the regulations as of Monday the 29th, which will enable people to meet in groups of 6 or no more than 2 households outdoors. And I think from my main message from that is, we've learned a lot in the last year about how COVID is transmitted, and being outside is significantly better than being indoors. So really would encourage everyone to maintain the hands, face and space, but also if you can do things indoors, then certainly do that, because I think both the physical and mental benefits of being outdoors, as well as the reduction in risk on COVID, means that it's definitely a good message. Thank you, Chair.
Thank you very much for that. Thank you, that's really useful. We wouldn't normally have questions here unless anybody's got a burning question to ask Rachel. We'll move on. I'm not seeing anything in the chat bar, so we'll move on. Okay, item 7, Kirklees Joint Strategic Assessment Overview 2021 and the Director of Public Health Annual Report 2021. Really snappy title. I understand both you, Rachel, and Owen Richardson are going to be delivering this to us. Are we starting with the JSA overview?
Thank you, Chair. I think if it's all right, and apologies for changing it at the last minute, we're going to start with the Director of Public Health Annual Report, because actually the JSA does draw on that as a data source. So if it's okay, right, I'm going to kick things off and then Owen will pick it up. Okay, so I suppose just what we've got today is we've got a presentation of the report, which I'm going to just pick out some key highlights for board members. And obviously what we'll be doing on the back of today's meeting is sharing it with you so that you can obviously have a look at it at your leisure, and obviously from my perspective use it in your planning going forward. We've used a new product to present it, so Owen is going to help to drive this, because obviously it's something that needs quite a bit of experience to be able to show in public, and because I'm talking at the same time, I definitely don't want to get it wrong. The annual report that we've done this year has been about health inequalities across the life course, and I think that none of you would be surprised that that was the focus that I was keen on this year, particularly given everything that we've experienced in the last 12 months. The purpose of the report is to explore the nature and scale of health inequalities experienced by our communities here in Kirklees, and trying to use a life course stages approach that can explore those health inequalities from birth to end of life. And what we want to try and be able to do is think about differences in outcomes that are experienced by different groups in our population, and how we can highlight them and address them in a priority. As a priority. And what we do know, and the reason why doing a life course stage approach, is that often inequalities that you experience in your younger years will have an impact then going through your life course. So intervening as early as possible is really, really crucial in order to change that trajectory in terms of those inequalities. As a board, we've talked a lot about the importance of the wider determinants of health, and actually, we cannot solve this through healthcare alone, and actually how we target and support and work collectively on those wider determinants of health is going to be the difference between success and failure. And obviously, being in the local authority for public health, it gives us a real opportunity to make that sort of difference. And it might be that we might not see those changes for generations to come, but we know that we're doing that, and it will have an impact in the long term. So the report has been written in a way that kind of articulates what health inequalities are, it helps to articulate how we could measure them, and I'd be interested in the board's views about whether we keep a set of inequality indicators as a health and wellbeing board where we can look at what we're doing and look at that on a regular basis. And obviously that's how we've tried to frame the Kirklees Joint Strategic Assessment this year, so that actually we are looking at not just things like life expectancy, but healthy life expectancy, and making sure those key inequality measures are built in to make sure as a system we're doing what we need to do. We talk about the factors that influence inequalities, and actually, again, picking up that wider determinant of health point, and actually the importance of intervening at different stages. And also, by taking a life course approach, we can pick out specific things that I think will give the board and the partners things that they could focus on and that we might want to take collective action on. There's also obviously a reflection on how COVID has impacted on health inequalities and how it has brought those inequalities into the forefront of people's mind, and actually hopefully given us a catalyst for action in a way that perhaps we haven't done before. And as the next item, certainly from a council perspective, and I know that the partnerships share this ambition, we've got an inclusion commission that we're about to establish that will hopefully help to drive some of this work. And certainly as a partnership executive, we've looked at how we can make health inequalities and inequalities more broadly our priorities. I think the other thing to say is that health inequalities and the conditions that lead to them are not inevitable. So actually there is a real opportunity for change here. And I think sometimes it's when something has been a certain way for a long period of time, it feels quite difficult to think about what you can do to make a difference. But I actually think with the collective power and influence in the board, and particularly with putting our residents at the heart of this, and if we co-produce solutions with them, we can genuinely make a difference. And I would really hope we would have that sort of conversation. The other last thing to say is that population health management is a way of being able to look at how we try and tackle those inequalities and measure the impact of that activity. And that has been a term that's been used for a number of years now. And I think it's something that we should definitely look at. And this report articulates where there's an opportunity to do that. Just before I move into a couple of the bits of the content that I want to focus on, I just want to probably do some thank yous, because obviously it feels kind of amazing really to me that people have worked so hard getting this out when we've been in the middle of all dealing with the pandemic in the past 12 months. So thank you to everybody in the teams that have been involved in that. There'll be a number of people who are credited in the report, and I just want to give a shout out to colleagues across the partnership and to the ICS, because we've worked very closely with their work on health inequalities and contributed to some of their workshops. And I actually think it's been really positive to shine that light on it, both at a West Yorkshire and Harrogate level and obviously at a local Kirklees level. So Owen, could you go into the life course stages for me? Okay, and if you can go to the new beginnings. So what this chapter seeks to do is to articulate what is the important factors of each of these stages, and it talks about the factors that make for good outcomes in that 0 to 2 year. We've got a description of the population. Owen, if you can go into that for me. And what you get in each of these sections is a slide that talks through all the different intelligence that we've got about what's happening in Kirklees and how many fit in that criteria and where the inequalities are. The one thing I want to draw attention to here is we are seeing an increase in our infant mortality rate. So you'll be aware that infant mortality is one of the key indicators in terms of health inequalities, and you can see that from 4.9 in 2015 to 17, we're now looking at 6.2 in 2017 to 19. That is quite stark, and we've put we've seen it. We saw a year-on-year reduction for quite some time, and the fact that it's going in the opposite direction is concerning. There are multiple factors factors that contribute to infant mortality, and we know that a lot of them are complex, and so some targeted work is needed to try and reduce that rate. It's probably worth saying that COVID itself has had an impact on the people accessing maternity services, as it has been with a number of other health services, and we know that good maternity care is part of what is needed to reduce infant mortality. So there are a number of things that we can do and that we can make sure we recover from as we come out of the pandemic. There are also differences experienced in different ethnic groups in terms of using maternity services, and the infant mortality rate in different groups is obviously different, and that's why we need to work at a place level within our communities. Thank you, Owen. So if we can just go to probably 18 to 34. So I think obviously early adulthood is a significant transitionary period, and actually people tend to have a lot of life changes at this point. And actually I think that moving to live independently is such a significant change that if people can be supported and can do that in a way that best increases their chances in terms of outcomes, then it's a really good period of time to intervene. Obviously, it's when people generally start on the employment ladder as well, and making sure that we've got good work for people is really, really important. As I said earlier, those who experienced inequalities in some of those younger age groups are more likely to continue to experience inequalities into this period, which is why it's so important to get us to intervene earlier. If you just want to go into the inequalities, please, Owen. So one of the things I just wanted to draw attention to here is that actually we've definitely got an inequality in terms of disability. So fewer than half of disabled adults in Kirklees are qualified to level of 2 or above. And actually they are more likely, disabled adults are more likely to live in a low income household. So we know that there are inequalities experienced by our disabled people in Kirklees. Interestingly, across Kirklees, we've adopted something called the place partnership approach, which is where groups of our elected ward members got together to look at how they could tackle mental health on a ward level. And that's a really, really good example of population health management, because it's taking a problem, looking at the intelligence looking at the intelligence as to why that's a problem in communities, and work collectively with fellow ward members and with the public to design solutions. And actually there's been some brilliant initiatives that have come forward, and it's different across Kirklees, which I think you would expect in terms of reflecting the different challenges across those areas. So I'm really positive about that, because I think that what has been put in place is some programs that can support the statutory provision and can hopefully influence policy if those initiatives are successful. So again, using intelligence and taking that population health management approach through that initiative has shown a really positive outcome. Okay, do you want to move to 60 to 79?
Yep.
Okay, so I think with this one, probably really important to mention COVID here, because we all know that actually age has been the biggest impactor on the experience of COVID within our population. We know that people who have been in that group we've had the highest proportion of the clinically extremely vulnerable in the 60 to 79. So then nearly half of the clinically extremely vulnerable in Kirklees. So not to mention the physical ill health that they're experiencing, they will also be disproportionately affected with mental health because of the social isolation they've likely to have experienced in the past 12 months. And again, for me, I was really struck when I was speaking to someone the other day about you know, there's one thing about being told I no longer need to shield, but there's something else entirely about taking that first step out of the door, and how we are able to equip people into feeling comfortable in doing normal things again and interacting with others. And I just think that's huge in terms of how we actually support people going forward, because keeping people safe while they're shielding is one thing, but actually making sure that people are supported to reintegrate and go back into some of those support groups or other things that they were acting is really, really critical. And what we don't want to do is for people to still feel like they don't want to leave their home and actually you know, risk that further decrease in mental and physical health. We do know that people in our more deprived areas and people from our BAME ethnicities are more likely to feel lonely in Kirklees, are less confident in managing their health and generally less resilient. So add that to the fact that COVID has a disproportionate effect of people in that group. That is really, really concerning. I also think it's important that we reflect on the fact that there are people tend to have multiple comorbidities within this group. So having diabetes and having well managed diabetes, and that being the only condition you have, is very different to someone who lives in poor housing, potentially has multiple different conditions and isn't a part of any good support network. And the disproportionate impact of COVID on those people has been huge. And I think that this group particularly is something that from a health service perspective, we can genuinely make sure we are targeting and giving people the confidence to support with those conditions. We've had huge success around some of our expert patient type programs and that peer support, and that is definitely still something that is really successful. And I know that through Swift and our other and our acute providers, that working on some of those is really, really important in terms of giving people that support and being able to talk to others about their conditions. And I know that certainly working alongside Locala and the PCNs on social prescribing is another way we can target some of those communities to make sure that we're getting that support that's not just about pharmaceutical intervention. I think I'm probably going to stop there. I'm hoping that I've given you a flavour of this, and obviously we will circulate this and you can have a play around with it and focus on the sections that is particularly relevant to you and your organisation and services. But I just want to go back to the point I made at the beginning, which is COVID hasn't created a new set of inequalities. It has brought to life those ones that already exist. So now is the time to be bold about how we can make a difference on those inequalities. And I just think that if we can put our communities at the heart of their own health and well-being and in the driving seat when it comes to creating solutions that work for them, I think that will give us a real chance to tackle inequalities and make things better for future generations. Thank you very much.
Thank you very much, Rachel. That's a fascinating set of infographics. I can understand why you're saying they're complex. Could I go back to something you said early on, and I'd like board members to consider. You asked the question about whether this board would want to keep a set of inequality indicators and measure against them as we go forward through the year. And for me, that sounds to be an excellent suggestion. I'm just wondering what board members consider about that, and if anybody wants to ask a question or comment. Carol.
Yeah, thank you, Rachel. On that point about a set of indicators, I think that would be really helpful, and I'd be keen to think about what's useful for the board and how that links to any work we might be doing in our own organisations as well. So we had a conversation this morning in our senior management team about our sort of renewed focus on health inequalities work from a CCG perspective, and again started to think about what are the key indicators that we look at the moment that will help build up that picture. So there are things that we look at regularly, but access to health checks for people with learning disabilities is the one that springs to mind, because that's very much in our minds at the moment, but there'll be lots of other things, and it's whether we can do some sort of work together to draw up what that set of indicators would look like. What would be useful to us at a high level here, and then what have we got that we need to sort of drill down on within individual parts of the system. But I think I agree. I think it'd be a really good idea.
Yeah.
Am I okay to come back on that, Chair?
You are indeed. You are.
Just to say, Carol, yes, completely agree with you. And I think inevitably there'll be a set of probably population level indicators that unfortunately probably only change on an annual basis. So sometimes they're more difficult to track in terms of kind of operational delivery. But as you've quite rightly talked about, the coverage of NHS health checks is less relevant than within specific groups and within specific inequalities. So if we can try and put some measures in that takes it from the kind of one size fits all to something that drills down, and actually looking at the differences in access between different areas of Kirklees might give you a better picture in terms of where you want to target more activity. So we can absolutely work with you on that.
That's good. I mean, Carol's right. It's not only this board looking at inequalities, but certainly for me, your 18 to 34 bit really resonated, and it made me immediately think of I chair the corporate parenting board, and actually what extra support do our care leavers need, because there they are at 18, often without any family network. We do provide for them, but perhaps we need to go an extra mile, and that really resonated for me. I'm just looking. Mel Meggs has put a comment in. It'd be really helpful to have some proxy indicators we could consider in year. I think that's a good comment. Shall we move things on? And have I got this right now that Owen Richardson's going to share the JSA overview? Is that right?
Yeah,
Or have
that's
I made
fine.
a mistake with that? Am I surprising you,
No.
Owen? Is that what you think you're doing?
Yeah,
Owen, I think hopefully does know he's doing that. But all I was just going to say, Chair, if it's all right, is I'm really happy to come to any of the partners' boards to talk about this report. I know that Karen from Local has already booked me in to talk at her board about inequalities, so really opening that up to anyone that wants to have that conversation specifically for their organisation, and I can tailor the report that would best work for whatever agency it is. So just to put that offer out there.
Lovely, thank you very much. So Owen.
Thank you. Yep. So I'm just going to very quickly talk through the latest version of the Kirklees Joint Strategic Assessment overview. We've got an agreement with the board that we'll get your approval for this section of the KJSA every year. It was November 2019 that I last came to the board and presented the previous version. We've gotten a little bit sidetracked in the last year, so the KJSA has it's slightly dropped down the priority list, but we're picking that back up now. If I just share my screen, and I'll go through the what the new overview section will look like. So when I go through this, you'll see why we've presented, or why Rachel's presented her DPH report first. We've very much taken the core content of that report. There's a lot of synergy between Rachel's report and the overview within the KJSA. We try wherever possible to highlight inequalities. We take a life course approach. There's an emphasis on assets, not just needs. Unfortunately, we haven't yet had a chance to reflect the impact of COVID-19 on the content of the KJSA. So we felt this was a really good opportunity to kind of encapsulate all of that by taking, as I say, that core content and just adapting it for the KJSA. So for the overview section, we've used the same 7 life stages that are in the DPH report. We've taken those common threads of population inequalities, COVID-19, and population health management. We've also embedded links to other KJSA sections, so it feels like it's more a part of the KJSA website rather than just being a standalone product. People are signposted to those sections and they can get more details on the specific topics. The navigation menu within the overview allows you to jump to any of the individual life stages straight away. And within those life stages, you can use the sub menu to select the topic, population inequalities, COVID-19 and population health management, or you could just step forward through the whole report in order. It depends how you want to kind of consume the content. If I just show you how it looks. So some of these will be familiar from the presentation Rachel's just gone through. So we start with population on each of the life stages. There are common graphics on each life stage, so you can see here the comparison between the Kirklees population and the England population for this age group, and also on the right hand side we've got the ethnicity breakdown. So as you step through, you can see how the population changes and how the ethnicity changes, and as you do that, you see that in our younger populations, we see that Kirklees has a larger proportion of younger people in our population compared to the England average, but then a lower proportion of adults, younger adults. And I find it quite interesting to step through and look at the ethnicity breakdown. So in that very first age group, so the 0 to 2 or conception to age 2, the ethnicity, white British ethnicity, represents just over half of this is based on ethnicity of mothers of babies born, but as you step through, you see how that proportion increases, and as we get to the older age groups, you can see we're now over 90% of our population is 60 to 79 is white British, and then by the time we get to 80 and above, 93% of our population, so the vast majority of our population. So you can see how the age profile by ethnicity varies. If I also pick out some of the sections that Rachel didn't focus on in her presentation, so if you look at the inequalities throughout are presented according to factors such as deprivation, ethnicity, disability, gender, and sexual orientation. So in our 3 to 10 age group here, we can see, if we look at the inequalities here, we can see that we've highlighted obesity levels for reception age children living in the most deprived areas are twice the rate of those living in the least deprived areas. And we also see differences by ethnicity. If we move into the 11 to 17 age group and look at the inequalities again, we can see the way that child poverty is increasing over time. And we can also see factors relating to LGBT plus young people. A much higher proportion have worries or worries at a higher level than non-LGBT plus young people. And also they tend to have higher levels of risky behaviour. In the 35 to 59 age group, we can see from the inequalities side, those living in the most deprived areas, those people of BAME, in BAME communities and males, they tend to have lower levels of subjective well-being and lower levels of self-efficacy than other groups. And skipping on to the age 80 plus group, we can see in the inequalities section here the differences, the large differences in life expectancy between the most deprived and the least deprived areas for males and for females, and also even larger gaps between the most and least deprived in terms of healthy life expectancy. Just to highlight a couple of the COVID-19 factors, As Rachel touched on, the age has been a major risk factor for poor outcomes from COVID. So this is represented here. In the 35 to 59s, we can see the impact of schools being closed for such a long time, the impact on working age adults, having to homeschool, the disproportional impact on women rather than men, and also a disproportionate impact by ethnicity of that. And then obviously in the school age groups, the impacts of disruption to education is highlighted across both those age groups. And also in that younger age group, we've put here around potential increased risk of experiencing adverse childhood experiences, the food insecurity, and the work the council has done to provide free school meals during the school holidays. So hopefully that gives you a flavour and explains why we've presented the information this way around today. Happy to take any questions on this.
So, colleagues, any questions or comments? I'm not seeing anything at the moment. I have to say, for me, in some ways, the way that you've put together the data, which is fascinating, is a great relief. You know, I can remember historically these reports coming, goodness knows how many pages long. And whilst I would wade through paragraph after paragraph, that's a much more consumable way. And the fact you can move about and do comparators and follow a thread of thought, I think is incredibly beneficial. It's really good.
Thank you.
Anybody wishing to comment or ask a question? No? Oh. Yeah. Rob's saying it's really powerful and great to see the ethnicity parts of that. So I think there's some really, really positive things there. If you look at the recommendations for this part of the agenda on page 14, it's not so much a recommendation, perhaps a call to arms. It's intended that board members will make use of the report to inform decision making and commissioning in order to help reduce health-related inequalities. The fact that the reports will be available, the infographics and so on to us all is invaluable. I would propose to the board today that we do move forward with keeping a set of inequality indicators and measure against them as we go through the board in the coming year. And it's certainly something I will be taking a lot of that information away to parts of children's services. I can see exactly how we can look to deliver better. Last chance if anybody wishes to comment or ask a question. In that case, and if nobody's disagreeing with me about that proposal, I'll take that as granted. Oh, Rob Webster, I'd love to add something. You're very welcome.
Thanks, Chair. I wasn't sure about the etiquette, given I'm just in attendance rather than a member.
Oh, no.
So thank you for letting me speak. I think that we're seeing a lot in the media and elsewhere around the white paper for the integration of services, and what that often focuses on in the conversation is structure. And I think what it should focus on is the intent, which is about tackling inequalities. So I really strongly support your recommendation about monitoring inequalities, and I strongly support the recommendations. And perhaps I'd suggest that as we develop the arrangements for implementation of the white paper in Kirklees and of integrated services, we should always be checking back that what we're doing is addressing the issues that are reflected in the needs assessment. Yeah. And we might want to find a systemic way of doing that, but I think it would be a really good test for us on how we're implementing those arrangements that it addresses these issues.
Yeah, absolutely agree. Thank you for that. Can I just point out in the chat bar that Mike Evans has said it would be of interest to the Kirklees Safeguarding Adults Board. And some thanks for going to Karen Jackson's board already. So I think you'll be getting lots of invites actually on the back of this. But thank you so much for that. I think that's an invaluable two presentations in one there. But thank you very much. Can we move therefore on to item 8, please, which is an update on Kirklees Inclusion Commission, which therefore links in very well, a development of the Kirklees Joint Health and Wellbeing Strategy. And Rachel, I feel it's you again, is it?
It is,
And
although Phil is going to drive the slides for me, and he's going to pick up the the strategy bit. So Phil, if you can put the slides up, brilliant. Thank you. Okay, so I just wanted to update. Oh, disappear. Oh, that's better. I just want to update the board on. Is it flashing for everyone, or is it just me?
I'm looking at just a static presentation. It looks fine.
Sorry, it's probably my my connection.
Oh dear.
Okay, so I just want to update the board on the Kirklees member-led inclusion commission. A report was taken into cabinet and endorsed by council in October in terms of creating a inclusion commission for Kirklees, which would genuinely try and tackle the issues that obviously I've highlighted in terms of health inequalities, but broader than that in terms of all the inequalities experienced for our district. And the objectives of that commission is to hear the voices of those with lived experience of inequalities and people in positions of power locally in terms of how they respond to that. Get some clear recommendations of action and listen to experts in terms of what can and could be done within a place like Kirklees. How we hold the system to account. So a bit like we were talking about there, Chair, about how we check and put a bit of rigour behind making sure that what we're doing locally does genuinely tackle inequalities and certainly doesn't increase them. And how we can influence at local, regional and national level to address issues, which is obviously outside of the remit of the local authority. Next slide, Bill, thanks. So what we've done is that we're very conscious that there's a lot going on at the moment, and we'd originally hoped to start this commission a bit earlier, but obviously the third lockdown and the fact that the whole system is working so hard on tackling COVID and supporting the vaccination programmes amongst other things, and dealing with winter, we've pushed it back to the summer. But what we've done is we've set up a shadow inclusion commission which starts on Monday. And the idea is that they can do a piece of work to set up the terms of reference for the formal commission, think about what engagement methodologies we want to use in that commission to make it the most effective. So how do we take it from kind of just talking into something that genuinely has teeth in terms of action? What we do in terms of independent advisors and how we focus on various deep dive topic areas. So my annual report that I've just presented here would be one of those sources of intelligence that can inform that commission, and also how we measure the success of the formal commission. So what success measures would we do that? And really trying to model that approach to inclusion so that when we're into the formal commission, what that might look like and how we can learn from other commissions in other areas. Next slide, Phil. So just for your information, the 5 deep dives that were proposed were health, housing, education, employment and skills, poverty and people. And obviously we would look at a number of protected characteristics and other characteristics within each of those 5 groups. I'm sure you will agree with me that actually a lot of those are very interdependent. I mean, that report I presented about health inequalities, to be honest, what influences health other than all of those things listed there. So the key will be how we focus on the deep dive areas, but we look at the interdependencies between those. So that's just an update of where we are with the Inclusion Commission, and obviously there'll be a communications plan to support that. And we are keeping the partnership updated, both the partnership exec for Kirklees and the health and care exec as well, on a regular basis. I just wanted to highlight the progress to the board. Thank you, Chair.
Excellent, thank you very much. There's been a comment in the chat asking if we could have these slides, please, and I was pretty sure that you would be happy to share them across board members and etc.
Yeah. I mean, we'll everything will go out in terms of the report for the DPH report, the newly hopefully launched JSA, and these slides can go out. Just to answer Beth's question, yes, it is the same thing. I think that they decided that Inclusion Commission felt better as a title rather than Inequality Commission, so it is the same thing. So apologies for
it's the new name for the Inequalities Commission.
Yes.
It's the Inclusion Commission. Fine, as long as we're clear on that. Any other comments or questions, board members, attendees? Anybody? No. We are asked, if you look at page 16 of the pack that you have, we're asked to welcome the establishment of the Inclusion Commission, and I'm absolutely sure we all do as such. And it really is about all of us, including all our partners, participating in the work of that, and I hope that's going to be happening going forward. We're asked to comment on the proposed approach to responding to the white paper.
I was going to pick that up with a couple of slides now, Councillor.
Okay, that's fine. Do that.
So we really felt like there was a flow to this that sort of hopefully made sense. And we've tried to capture some of that on this slide with a set of areas that feel like they're moving all in tandem, hopefully. We actually came to the board in September just to remind the board that the board's got a statutory responsibility to make sure we've got a joint health and wellbeing strategy, and our current one is coming to the end of its life. So we need to start thinking about what the new strategy will look like. We had hoped by now to have done a bit more work on it than we have, but COVID continued probably with more vigour than we'd anticipated back in September. We know, I think a couple of people have referenced it, Rob just mentioned it, there's been a white paper published by the government about a set of changes to the way in which things are organised, with an increased emphasis on the integrated care system at a West Yorkshire level, and the importance of developing our sort of local place-based partnership arrangements. And the previous items on the agenda around the DPH report, the JSA, and the Inclusion Commission, there's an awful lot of things changing. So what we've tried to do in this slide is just capture some of those things and just test out with the board whether or not they were endorse the approach we're taking, which is viewing the three main tasks that it feels like we've got. One is to make sure we've got a joint health and wellbeing strategy that reflects our ambitions across the piece about how we can improve health and wellbeing for people. The health and wellbeing plan that tries to sort of describe what the health and care system in particular can do to contribute to achieving the aims we set out in the joint health and wellbeing strategy. And the integrated partnership, which are the partnership arrangements we've got that are going to evolve significantly, we think, over the next 12 months. And doing one of those things separately from the other doesn't feel like a sensible approach. It feels like they need to develop and evolve together. And we're very conscious of the fact there's a set of drivers. We've already referenced the outcomes for Kirklees that we've had for a while. The DPH report, we talked earlier about the West Yorkshire ICS strategy that was agreed last year and will evolve as the ICS develops. And there's a real strong sense that we need to concentrate quite a bit of effort on continuing to do a lot of the things we've already made significant progress with and made significant improvements on the back of that, whether that's developing primary care networks, improving the way our support for vulnerable children is coordinated. So rather than it just being about writing more plans and strategies, we need to devote some effort to keeping the really good developments we've got in train going. And almost as a consequence of all that, make sure that we're responding to the changes in the white paper. And out with the things that are within that remit, there's a set of other elements, the context that keep changing, that we just need to keep reminding ourselves of and keep making the connection. The obvious things around COVID, but critically about what are we doing around economic recovery, which is clearly going to be a big challenge for all of us. Making sure we're keeping in close touch with the Inclusion Commission, particularly the elements that are pertinent to health and wellbeing. The West Yorkshire changes are not just the ICS, but also there's going to be a West Yorkshire Mayor, which in terms of some of those broader agendas about economic development and transport will hopefully start to be clear what the impact is and how we can play into those. So the proposal as it stands is to make sure that by the time we get to March 2022, we have got a clear set of arrangements for integrated care partnership. We know what the health and wellbeing system is trying to deliver, and all of that is contributing to the bigger challenge of what's the joint health and wellbeing strategy that also brings in other partners and other elements of the system, whether that's the changes to the environment, housing, etc. So the sort of summary of that for us is that it feels like there are three key tasks we're involved in at the moment. One's remembering to get on with what we describe as the real work, because improving outcomes for people, whether that's birth outcomes or end of life outcomes or whatever comes in between, is ongoing work for a huge number of people, and we need to keep our eye on that and make sure it's continuing to evolve and improve. In terms of the new system, we need to focus both on inequalities, the integrated care partnership arrangements, but also those enablers and the core functions, because we're going to have safeguarding being a good example. We need to make sure we're clear through all this quite significant period of change, that we've got those basics right. We know where the money is, we know how well we're doing, we're making sure our most vulnerable people are protected. And the third thing is about making sure our contribution in shaping the West Yorkshire ICS arrangements, because the ICS is very clear that it's about the primacy of place and the importance of the 5 constituent areas in the ICS. And we need to make sure that we've got a clear position from a Kirklees perspective about what we think is going to be best for our local people, and make sure that informs what's going on in terms of the evolution of the West Yorkshire arrangements. So that's our 2-slide summary of where we think the challenges we're facing and what we need to do to both respond to the white paper and get to a point by the end of this coming financial year where we've got a joint health and wellbeing strategy that reflects all that change and what our ambitions are for Kirklees.
Thank you very much, Phil. So, board members, this is the second and third bullet point under the recommendations on page 16. It's asked for comment on the proposed approach in responding to the white paper, and also, do we approve the timetable for producing a new joint health and wellbeing strategy? So, any comments or questions around any of that? Yeah, Rob.
Yeah, thanks, Councillor Kendrick. So just for people who may be watching this or don't know, I'm also the lead chief executive for the West Yorkshire Harrogate Health and Care Partnership, otherwise known as the Integrated Care System, or ICS. And I really strongly support the approach to ensuring that Kirklees has a good plan which builds on the needs of Kirklees citizens, as we've seen from the excellent presentations from Rachel and others, and that we take as much responsibility as possible for driving change in Kirklees. And as Phil said, we've already got an integrated care system, the Health and Care Partnership, which is built on a principle of subsidiarity. So things get done and delivered as close to the person as possible, in their home, in their neighbourhood, in their town, in Kirklees or in West Yorkshire, depending upon the issue. So most things in the future will continue to get delivered, designed, paid for in Kirklees. So I think the development of this plan, building on the sort of 3 interlocking elements that Phil described, is an essential step, because that's what will continue to be the case in the future, that everything gets done at this level. So I really strongly support the recommendations. I think the comment I would have is that we amongst the leadership of the partnership at West Yorkshire level, we've got a set of maxims that we always come back to, and one of them is that real change happens in real work. So I think as we're designing, the place-based arrangements for the future, they've got to be designed and delivering the real work, as Phil described at the start. It's how are we tackling the health inequalities that people face? How are we restoring services that have been affected by COVID over the last year? How are we addressing the wider inequalities? So I think I really welcome the focus on the plan, welcome the focus on the place-based arrangements, and welcome the focus on real work, because that's how real change happens.
Thank you for that. I note Tom Brailsford completely agrees with you, as I do too. Are board members happy with that? Any other comments, or we're all happy with that? Can I just say, I almost feel I've been a little bit lightweight in terms of items 7 and 8, which have been really quite key factors in this, in saying thank you for the report. I do recognise what must have been the sheer volume of work that's gone into these and the complexity. So, my thanks to everybody involved for producing something I think that is so clear and quite innovative. So thank you very much. So I am taking it then that the board approves the approach to the white paper. We do welcome the establishment of the Inclusion Commission, and we approve the timetable for the new joint health and wellbeing strategy. Yeah, okay. So could we move on therefore, please, to item 9, which is the revision of the terms of reference of the Health and Wellbeing Board. Phil, I believe this is you again.
It is Councillor Kendrick. Sort of follows on a little bit from the previous item, because there has been quite a few changes during the past 12 months. We last reviewed the terms of reference more than 12 months ago. So this is really just a way to update them to reflect the new realities. So a few things. One is that the CCGs are merging as of the start of the new financial year. So we did previously have representatives from both CCGs, Great Huddersfield and North Kirklees. So we've basically reduced that to the same type of representation in terms of the clinical chair, the accountable officer and a lay member, but they will be representing Kirklees CCG rather than the two as previous. Similarly, in year we've changed the arrangements underneath the board. So we did have a separate commissioning board and a provider board, and they've been brought together into the Integrated Health and Care Leadership Board, which is a bit of a mouthful, but that is an indication of how we've been moving very much in the direction that's supported by the white paper, to bring together commissioners and providers to think together about what's best for Kirklees. So Karen Jackson has been the representative from the Integrated Provider Board, and we'll be looking to have a representative from the Integrated Health and Care Leadership Board, and we'll need to have a discussion at that board who they want that to be. There are already numerous members of that board who are members of the Health and Wellbeing Board. because the 3 directors from the council and all of the chief execs from the main local NHS provider organisations are actually on the Integrated Health and Care Leadership Board. So in terms of making those connections across the system, that should be extremely helpful. I think the other change worth noting is that in year we also changed slightly the governance arrangements for the children's partnership, and we did actually discuss this a few meetings ago, September I think it was, and so to formalise the arrangements that we discussed previously, it's just written into the terms of reference that the Health and Wellbeing Board is providing the sort of oversight of the work of the Children's Partnership, and on that basis the Director of Children's Services is coming with sort of potentially 2 hats on, one as Director of Children's Services, which is the requirement of the legislation, but also as a representative of the Children and Young People's Partnership. The final thing, which is not a change of membership particularly, but a slight change of how we describe people, because we've had, since the board was established a number of years ago, a range of key partners who've been invited observers, and that's increasingly felt like a slight anomaly, because what we've always tried to do, and the board's always encouraged, is people to participate fully and actively in the work of the board. And having people who are described as observers who are clearly active participants seems slightly anachronistic. So we've basically recognised that and said that each of the key healthcare providers in the district should have a representative, and they are a non-voting member. So we haven't actually changed the voting allocations or the things we need to meet in terms of being quorate and being able to vote. It just means that rather than describing people as observers, they're actually non-voting members.
Okay, thank you. I think the details of that are encapsulated under item 3, the proposal, on page 18 and on to 19. And the recommendation is that the revised terms of reference and membership of the Health and Wellbeing Board be approved. Somebody's Mr. Dr. Ollerton. I was turning you into a consultant then, Steve. You want to come in?
Yeah, thanks, Viv. I mean, obviously, we've recognised the new Kirklees CCG, which is the obvious thing to do. But I did notice a bit about PCNs, primary care networks.
Oh, apologise if I got that. Yeah.
And I wondered how. I mean, I know in the terms of reference you put about the federation, perhaps. I don't know what people's views are on that. I mean, for those who don't know, we do have 2 federations, My Health Huddersfield and the Cura. So how we include those is an interesting one. It's difficult, really, because we have to draw a line somewhere, don't we, at people being on the board. Otherwise, we could end up with every man and his dog. Not that I'm saying our PCNs are every man and his dog, of course, but it will be difficult. You know, there's 9 of them. Is anybody representative of all 9? I don't know.
Yeah.
I don't know what other people think.
I think that's a challenge when you're talking about somebody, one person representing 9 different arms of something. Phil, have you got any thoughts on that?
It was something we had a bit of discussion about. I don't know if Carol wants to come in. Yeah, I don't think any of us are particularly clear how we can best do that, because in terms of the use of the certainly the clinical directors of PCNs, having 9 of them sat here on a regular basis wouldn't seem like the best use of their time. But having somebody who can represent that perspective feels important, to be able to feed into the board, because we were slightly conscious of the fact that because we were going from 2 clinical chairs to 1 clinical chair, that sort of reducing the clinical leadership and the clinical input into the board's discussions.
All right, Carol, and then Richard, please, and then Rob.
I do think it's a tricky one, actually, and I'm not necessarily sure I still have the answer, because as Phil said, we did debate it a little bit. I think what was quite clear in my mind was that the role of the PCNs is different to the role of the CCGs. So the PCNs are provider networks, and that's different to the role that the CCG currently has. I know things are changing. And for me, it's just whether or not we ask them. The way it's written there, in my view, gives PCNs the choice. So what we're saying is, if the viewers would like a clinical rep, that's the other thing. Maybe we just need to firm up a clinical rep from the PCNs, which could, if they wish, be managed through the federations acting on their behalf. Then perhaps we could just ask them and say that we are looking for one member. But it is a difficult thing, because you're right. A PCN clinical director works for their PCN, and the extent to which they can represent the whole of Kirklees is going to be tricky. But it might be the best we can do for now, because we're going to have to look at all of the membership of all of our various future governance arrangements as we prepare for next year anyway. So I think it's just trying to be a bit pragmatic at this stage.
Okay, thank you. Richard?
So I wasn't going to be helpful, I'm afraid, and offer a solution, but more to reflect. This feels like the challenge that we need to work through over the coming year, because what we can't be is in a position, if we are going to build an integrated care partnership that's based on trust, collaboration, and a range of perspectives, then feel that every organisation has to be there representing an organisation rather than a kind of a perspective or just being able to contribute a view. And so we are in that transition space, and it's perhaps about being able to bring it's probably about being able to bring that locality view rather than being able to represent kind of the views of PCNs per se in the round. And that's just something we're going to have to work through, because otherwise, you say, Steve, there are also many other players in the system who could bring a valuable perspective, but actually if we invite everyone into the room, we will end up sort of hiring the John Smith Stadium for our first kind of in-person meeting again.
Oh, exciting. Rob Webster, you want to come in then, and then Rachel?
Yeah, thanks, Chair. I think Richard's made many of the points I was going to make, which are really about this will have to change again, won't it, as we respond to the white paper. And we might just want to build in a review at some point so that we can have a health and wellbeing board that reflects the job that we want to do in the new context. So if the white paper comes into legislation and there's a focus on collaboration with provider collaboratives, place-based working, primary care networks taking more of a role, we'll probably have to think of ways in which, however we run the provider collaborative within Kirklees, there's somebody who reflects that. However we get the PCNs to work together, there's somebody who reflects that. However we want to get the citizen voice into the conversation, there's somebody who reflects that. So I was just going to say 2 things really, that we probably just need to, this is a good first step, but we'll need to review it again later. And secondly, very happy to become a non-voting member.
Good stuff. Rachel?
Yeah, just to follow on that, and I just wonder whether if we are cute with the agendas going forward, then maybe that would lend itself to kind of different people coming to be part of that discussion. So rather than it being about the board membership in its formal sense, there's a level of almost co-optees. Again, that's probably a bit too formal for what I'm articulating, but if we're going to be having a discussion about X, then there'll be people in the system that have a voice and a view so that we can reflect that. And I think that's where, for me, where inviting PCN reps into that might be the best way of doing it, which I suppose you don't need to necessarily reflect in the terms of reference, other than we might bring people in for the discussion, because in the voting element is few and far between, I would suspect.
It is indeed. Mike Evans' hand suddenly shot up.
I know it's not the item I'm here for, but just to say that I think the conversation's going in exactly the right way. From my own experience in Manchester, the important thing was to make sure people could contribute in the way that they feel they needed to contribute to the redesign of the service, and know that there was the necessary conduit into the governance procedures that gave them permission to change in the way they wanted things to change. And I feel that's the direction the conversation's going. It's pointless just putting people on a board thinking that will solve it. I think what solves it is having the engine or engine rooms operating that enable people to have their voice heard and contribute to the new design of service.
Thank you for that. I think there's some really positive comments there, and let's remember this isn't written in stone. It is always movable and changeable, and as has been said, it's probably going to have to change again. I like the idea that there's an opportunity for people who have a particular interest voice on some subjects, and I wouldn't at all be unhappy about the PCNs and federations being asked as to what they feel is good representation. Anyway, I think that's another hand just gone up, but I'm not sure. Is that you again, Mike, or is that you've just left your hand hanging?
No, I probably left my hand hanging. I do sometimes. Okay.
Indeed, that's exactly like you. So I think that there's some really good sort of comments and contributions there. I think it's we have to make a decision as such for now, but let's take it that it's a work in progress that we will keep improving on. Are we happy with that? Are board members happy for us to go forward with what the proposal is as such? Phil?
So it was just to reiterate that point. We've put something in the report that basically says it's almost inevitable we will have to change this in year. So whilst the formal process will get it through the council's processes shortly after the elections and the first full council, we will need to change it in year.
Absolutely.
So.
And yeah, and we're always willing to know if we've not got it right or we've not got it quite right. We are always willing to change and get it better. So fine. I'm going to take it that the board's happy with that. Can I move us please then to item 10, which is your moment, Mike Houghton Evans, Kirklees Safeguarding Adults Board Annual Report 2019 to 2020.
Thank you, Chair. You've all had the report. The annual reports are necessarily dated by the time you get them. They've been through the scrutiny board and they've come to you. So with permission, Chair, I'd like to bring you a bit more up to date with how we're approaching things over the last 12 months, which I think is probably more of relevance to where you'd want to hear me talk. We did, just to summarise, we did embed the recommendations that came from the peer challenge into our work programme, and they've been fully actioned. The one I'd like to highlight is that we're very pleased with the way the practitioner forums have been used and developed, and that's our main mechanism for getting that golden thread through strategy to frontline service, and it's proved to be very effective. And if you want a tangible example of that, we'd blindly signed off a strategy and procedure around self-neglect, but it's only through then engaging effectively with frontline practitioners that we realised it needed to be amended, and it has been, and it's much more effective and well received now. It's just one example. And in the past, I think we would have blindly thought we'd done the work, done and dusted, we can move on to something else. The main thing, and it's been mentioned several times today, is COVID-19. As a board, we recognised that we couldn't simply think our work programme and our attention to performance as it would be sufficient during that period. So we developed our own risk register, and monitored that regularly. And the core members of the board, and initially for the first few months, met 4 weekly. That's health, police, social care, and myself, met regularly to review and update a risk register. To be honest, I don't think the risk register threw up things we didn't already know. It just brought them into close sight, really. We've heard a lot about inequalities today, and clearly that's something that's become much more obvious during the last few months. We are committed and continue to be an outward-facing board. We know that we can't achieve our objectives on our own. We treat ourselves as a group of system leaders, and as such, we want to continue to collaborate closely with those other bodies that look after the health, well-being and safety of the communities in Kirklees. So that includes your board, Health and Wellbeing Board, Children's Safeguarding Board and the Community Safety Partnership, Safer Kirklees. To use a well-worn expression, I would suggest that over the last year, that work has been subject to a circuit breaker. It hasn't really happened because realistically, everything else has got, taken priority. It needs to be re-energised. As you know, Councillor Kendrick, we do every so often re-energise that piece of work.
Indeed.
We've just completed the challenge event, and the challenge event is where every year I meet with each board member separately, and I'm accompanied by Helen Hunter and from Health Watch, and Penny Renwick, who's the independent layperson on the board. And so we have a conversation with each of the board members about what the issues are. The report's not written on that yet, but just to summarise, I think what a couple of the key findings are that we will watch very carefully. Not naming names, there are some organisations that are very effective in demonstrating that they are in touch with the impact of their services on their patients or service users. There are some organisations that are more effective about demonstrating they've got the procedures in place. So they've got the documentation, but not necessarily strong enough systems for measuring the impact of the services. And I mention this because there's something else that's cropped up that the board will want to keep an eye on, and you may want to keep an eye on as well. There's something called the new normal. And the new normal is an expression that people are often using to say there are some benefits from the way we've been engaging with the public, which we'd want to keep. And that will change, that will create a new normal. And I think that's code for saying we won't need to do as much face-to-face contact as we have in the past. We will be able to use technology in different ways to look after the welfare of those people we serve. And that's correct, and that's right, and that's probably very efficient. What became apparent during the sessions we had, the challenge sessions we had and the conversations we had, is that people are aware they need to be careful they don't fall too quickly into the concept if you can use checklists to decide who gets what. There's got to be that professional judgment, and that professional judgment has to be preserved at all costs. When people are under pressure, if they get things, standard questions that they need to ask, and you know, if you say yes to 3, therefore we can do a remote interview, then I think we've got potential for unintended consequences, is the way I'd put it. So it's just something we're going to watch out for. And from a board's perspective, we're going to, over the next 12 months and more, hear more real life stories and not just look at the numbers, but look at some real stories. And Health Watch are going to help us do that in particular. So that will be of value. Finally, last year, I said I wouldn't be here this year, and I am. But next year I won't be, because joining us today, and he's been here for the whole meeting as part of his induction, is the new independent chair of the Safeguarding Board. Rob, can you put your camera on? Are you still there? Oh yeah.
I'm still here.
Right. Can I introduce Rob McCulloch-Graham? Rob's the Chief Officer of the Integrated Health and Social Care Partnership in Borders region. He's thinking of moving on and retiring, but he spotted this job was being advertised in The Guardian. He rang me up and said, "Mike, is that your job?" Because I know Rob, right? And I said, yes. And he said, "Would you mind if I apply?" I said, "No, I'll be delighted." So, Rob, do you want to just introduce yourself a little bit, please?
Well, thanks very much, Mike. And hello, everybody. And thanks very much for allowing me to sit through the meeting with you, which is absolutely fascinating. Mike has been very careful about my induction. He's got a very vested interest, I think. I don't think he really wants to go at all. And I just wanted to give my public thanks for him. So I sat through the challenge sessions with Mike, and again, I was very grateful for that. And I was really, really encouraged to hear the conversations that each of the different agencies and each of the different people that were represented there gave around safeguarding as a whole. And what was really encouraging around that is what Mike has just been saying, really about making safeguarding personal, and those stories that each of those people were able to give really brought it to life. I think it's a very interesting time, listening to your conversation today, to be actually joining Kirklees with all the changes that are coming from the white paper. And I think one of the challenges I may well be picking up is maintaining all of the good work that Mike has led and the partnership has led in all of the changes to the different boards that are going to be formed. So I think it's exciting times to come down. But thanks very much for the time and invitation to join you today. Really appreciate it. And I look forward to working with you all. Thank you.
Okay. You're very welcome.
Okay. Thank you, Councillor Kendrick. Any questions? I'll try and deal with them.
Any questions, anybody? Any comments? Oh, people putting hands up, and when your picture isn't up, I have to search you out with my mouse to see who you are. I don't know who it is, but whoever's got the hand up, would you like to speak, please?
It's me, Councillor Kendrick. It's Beth. I do have my video on, but it's obviously not showing your end.
No, it's not showing. No. Not for me anyway, sorry.
So I just had a couple of questions, really. So the first one was around, I think it's really great that Healthwatch are being commissioned to do this additional work to seek the views of people and their views and experiences. But I just wondered if there was more of a partnership approach as well. I think, during COVID, it's going to be difficult to capture some of those views as well, even though we're coming out of that now. But I think it's really important if it's ever going to be a really person-centric way that more people are involved in generating those experiences of people as part of this work. So that was my first thought. And then secondly, just looking at the safeguarding concerns, I think it's levelled out, isn't it, for the 1819 and the 1920 numbers. And I just wondered if there was a picture of what the next year's numbers are looking like, given that maybe we haven't been able to capture some of those informal conversations that people might have been having to capture those safeguarding issues. So those are my questions. Thank you.
Okay. You're quite right on the first question. It's not only Healthwatch, and in fact, as part of the challenge event, we asked people to come along with some examples of self-neglect situations that they've been faced with, and a couple of those we've already identified as worth presentations to the board. So no, you're quite right. It needs to be a partnership approach. Healthwatch can always bring us materials, and we want to receive that from other people. You're quite right also. It's far too early to say what the figures are going to be like as we come out of COVID. They fluctuated a bit going into it. They've gone up again a bit. It's an area we're going to watch very closely. The particular focus that we're having at the moment is around social isolation and self-neglect. We ran a major workshop a couple of weeks ago. We had a national speaker at it. We had over 100 attendees from across the whole partnership who came. It was well received, well organised. It really showed the potential of teams to run such a large event. It really went well. And there's learning that's come out of that and as well. But if you ask me what the major theme that we're going to pick up on over the next 12 months, it's going to be self-neglect. The interesting thing is when you look at safeguarding investigations and safeguarding adults reviews, they tend to get labelled according to the type of abuse or whatever you want to call it, whether it's financial abuse, whether it's neglect or whatever it is. Hidden underneath that is quite often an element of self-neglect which isn't recorded. And that would, if there was a theme that came out of the workshop, it's the research that's been done nationally into safeguarding adults reviews, which exposed that as a major area that people need to focus on. And the reason for that is that it's tempting to say somebody has capacity and do a mental capacity assessment, and then allow things to drift. And the message clearly is, professionally, you don't have to do that. And we now have a policy in Kirklees which allows for early escalation if somebody is concerned, but even when there is capacity is deemed to be there, which allows collaboration between all the agencies to say, what can we do together which might be more effective in tackling this? Okay, they won't let the social worker in, but how's the district nurse? Is district nurse being accepted into the house? And you can start to plan differently about how you develop the relationship and support an effective and helpful intervention. We've done it in Kirklees effectively around hoarding. That was an initiative led by the Fire and Rescue Service, but it's broader than that. It's about a whole range of things.
Thank you very much for that, Mike. I'm not seeing any other questions as such. I have to do the business of the day with this, in that the board has to formally receive the Kirklees Safeguarding Adults Board annual report. Somebody's trying to ring me. I'll just throw my phone out the floor. Before we finish, if I could just say, Mike, I've known you for many, many years. We were young.
Oh yeah. I was a principal social worker when we first met.
Indeed.
Yeah,
and when I was doing the cabinet role for adults, I absolutely enjoyed working with you. I have to thank you for the work you've done on this. You've made a fantastic contribution to Kirklees, and I can only thank you and wish you well. And it isn't that I reject Rob joining us, Rob McCulloch-Graham joining us, but I will be missing you, but wish you well for the future, and thank you very much.
Yeah. Viv, I have promised people that when because I'm from Leeds, I do come down every so often when I'm allowed. Not allowed out Scotland at the moment.
Well, exactly.
But when I will come down, I have promised people I'll pop my head in. So I'll pop my head in and see if you're around as well.
That'll be lovely. Thank you very much.
Okay.
Thank you. Can I move us then to item 11, please, which is the Kirklees Safeguarding Children Partnership Assurance Report, and I think Tom Brailsford is just going to do that with us, please.
Thanks, Councillor Kendrick. Yeah, you'll notice that I'm not Sheila, and that's unfortunate because Sheila can't be with us today. So I'm just introducing and presenting the report on behalf of the statutory partners. And obviously the report's been produced by Sheila as independent advisor to the Children's Safeguarding Partnership. So I make the assumption that members have had an opportunity to read through and look at the detail. Obviously, the report sets out the work of the multi-agency partnership for the preceding year and also articulates the priorities moving forward. We know there's a requirement under working together to produce an annual assurance statement, but we go a bit beyond that and we provide a fuller report. And as a partnership, we've continued to do that. In order, and what that allows us to do is demonstrate impact with the data. And overall, we've seen positive improvements this year. And I think the view of Sheila is that there's higher levels of assurance that continue through that. So it's worth noting it's the first annual assurance report since we changed to our new arrangements from the Safeguarding Children's Board to the Safeguarding Children's Partnership. So it covers the first year of operation as a partnership. And obviously, as part of our philosophy, you have the choice of the three statutory partners about who you include and work with in the new arrangements. And we've kept that as wide as possible and as integrated as possible, which I think is what you'd expect us to do. Obviously, worth noting that there's been an impact throughout COVID-19, but as a partnership, there's been a continued ability to carry out the full range of expected functions. And I also think it's worth, publicly saying a big thank you to all the partners across children's services who've been able to carry on and keep children and young people and families safe throughout the pandemic. I think the response has been fantastic, and actually the structures which we have in place and the meetings in some cases have been more frequent. Certainly we had assurance meetings through the exec that were fortnightly, I think, initially throughout COVID. So there's been a real effort across the partnership to keep our children and young people safe, which is great. I think in the one of the things I just wanted to pull out from the report, which you'll see highlighted, and I'm sure you're aware of, but throughout the last year we had the review undertaken by the DFE and Leeds in terms of the improvement notice and the 6 tests that they'd put in place that we needed to meet, and following that review process, the improvement notice was lifted because we'd met those 6 tests, one of them being strong and supportive partnerships. So again, provides further assurance that Safeguarding Children's Partnership is doing what it needs to do. At the moment, as it stands, we're doing a number of things. We're further developing our model of independent scrutiny and what that looks like, and Sheila's doing some work on that for us at the moment. We've had a number of practice learning reviews this year, which I think, again, it's worth highlighting in terms of good practice. We've had them about serious youth violence, child sex abuse, CAMS issues, and contextual safeguarding. And what that means really is getting frontline practitioners together to talk about learning from reviews, which I've been involved in a couple of them, and I think people are seeing that as a real positive, and then that learning's feeding back into practice. So that's really positive. I think moving forward, as you'll see, the priorities for the coming year, we have 4 priorities: domestic abuse and children in households. Well, domestic abuse is a feature. Child criminal exploitation and abuse, children and young people's mental health, including the response to adverse child experiences, and widening the scrutiny function to look at including children and young people and families in scrutinising our services. So that's just a bit of a whistle-stop tour of the content from me, but obviously comes to the board for information and also for comment and assurance. Thanks, Chair.
Thank you. Anybody got any comments or questions? Rob Walker? No. Webster?
I think I didn't realise I had to change my name as well, Councillor Kendrick.
Well, all that's coming up on my stream is WR. Sorry.
So, oh, that's okay. I think I was Rob Website once before as well, so that was interesting. Auto-corrected. So thank you for the report, Tom. And I think, does the 4th of those recommendations capture the link between child safeguarding and adult safeguarding? And how are the 2 sort of sets of priorities between the 2 boards linked, is my first question. And the second question is, we just had a 3-day event on trauma-informed policy and delivery. And I wondered how that kind of thinking with the West Yorkshire Violence Reduction Unit and the outcome of the 3-day event can help inform the priorities for the Children's Safeguarding Board.
Yeah, I think they're really good points, Rob. In terms of the scrutiny, obviously we want to link that across boards, and we'll be having conversations about how we do that. Particularly in terms of parents, particularly in terms of domestic violence, and looking at how that interface works. And Sheila's working up some models of that, and so we'll definitely link that across. And I'm sure Mel will come in on that after I've just finished on the trauma informed. In terms of, I had some feedback, actually a few people were there at the trauma informed workshops. I think it's really positive, and we're just developing a number of models around placement support. We're looking at what our emotional health and wellbeing offer is, looking at trauma informed practice in school settings. So it's really starting to influence people's thinking and moving forward. And I can definitely feedback that in terms of back into the exec about where trauma informed fits within those priorities, Rob.
Mel, you wanted to come in as well?
Yeah, thank you. Just to sort of echo, so we've had a tradition where the board chairs have come together, and the statutory requirements obviously for children's have changed, and so we just need to make sense of how the statutory holders will be able to come together with the board chairs for adults to agree joint areas of work. Domestic abuse is obviously one of those areas where we absolutely need to do that. We know that for probably at least half, if not more than half of the child protection work we have, there is a relationship with domestic abuse. We know that those children vulnerable to exploitation will have grown up in homes of high conflict, including domestic abuse. So there is an absolute crossover there that we need to think about how we work together on. So as I say, we've been in a transition year, moving away from a traditional board chair into a board scrutineer. So that's why we're just still working at what that model looks like, and we've been really keen to make sure that we engage and hear the experiences of children, young people and their families who have been through the child protection system particularly. And that's often been problematic, and I think we'll be one of the country's leaders if we are able to get a model where we can talk about learn really from the experience of people who've been through that in a systematic way rather than an ad hoc way, I think, which is going to be really important for us. Yeah, to echo what Tom said around them, I sit on the exec for the Violence Reduction Unit, and using trauma-informed practices is one of those things that we want to do. We've developed a new youth engagement service, and underpinning that will be a trauma-informed practice model. We use MST as a model, which is all about understanding trauma. So that's going to be writ large, if you like, through the practice model. So I think there's some massive opportunities really to support our young people through that.
Thank you.
Yeah, could I just make one sort of follow-up comment, which is really welcome all of that. As I seem to have frozen. Can you hear me still? All right.
Yes, we can.
So I just really welcome all of that. I think I also can see the link between this and the earlier conversations about public health and prevention and planning. And I really think the strong emphasis over the last 3 days of the trauma-informed work around a public health approach to things like violence and crime is something we should be focusing on here.
Thank you. Rachel, you wanted to comment, and then I have Mike Evans.
Yeah, it was just to kind of pick up a few of the points that Rob's just made, actually, as he wouldn't be surprised for me to. We have a Kirklees Tackling Violence group, which takes the public health approach to tackling violence, and the Health and Wellbeing Board will recall we did a presentation when we could meet in person on what a public health approach meant and how we could embed that. And I think, as Rob's alluded to in terms of the earlier presentations, having that strong focus on the life course shows the points at which, it's about how people progress through their life, and it's not just being defined as a child then an adult, and never the twain shall meet. And certainly through our bigger transformation programs, we always have that challenge about how we are looking at those transition points and what happens in earlier years and how that influences the later stuff. So I feel really confident that we've got that embedded, and certainly when we're looking at how we look at commissioning across the local authority policy in a way that best achieves our outcomes. It's very much going to be not from a like children and adults perspective, and much more from a kind of what's going to make sense in terms of the life course approach. So, I mean, there's always more we can learn, but it feels like we're definitely on the right track with that.
Thank you. And finally, Mike Evans. Hello, Mike.
Yeah, it's all right. I'd switched myself on. Okay. Well, I was very pleased to hear Rob's comment about collaboration between the boards, because it's so important. The way I describe it is that the boards are constructs that are there because government and policy says they should be there. There should be something for children, something for adults, something for community safety, all the rest of it. But essentially, as public servants, we're there looking after the health, well-being and safety of our communities. And we fail if we work in isolation. We fail dismally if we work in that. We can only succeed if we collaborate. And that's why I think, I did use the word circuit breaker. That joining together of the chairs of the boards really has the potential to take forward those thorny issues that get missed if you're not careful, and do enable us to actually deliver what we're there really there to deliver. Boards don't actually deliver services. Boards hold agencies to account for the services they deliver. In a sense, they have a performance management role, they have an enabling role, and they have I suppose, an intelligence role as well, and a system leadership role. But we can't do it. An adult board can't deliver what it needs for adults without working collaboratively. We have to make those artificial constructs that have been put in place work better. Viv, you and I talk about all those years ago, 45 years ago we met, right? There was no separation of adults and children in those days.
Absolutely not.
We worked with families.
There were people.
Yeah. We weren't constrained by you can't do this, you can't do that, you can't do that. We did what we needed to do. Now I'm being a bit nostalgic because there were reasons things have changed since then. But, and I see Mel nodding. But there've been costs and benefits to every model. But we have to, as representing organisations, representing public services, we have to recognise who've created barriers, and we have to find ways of getting over that. And I think that's probably what was behind Rob's question. But it's so important, and we really need to drive that collaboration between the boards, because it doesn't happen by itself.
Thank you. Tom, I hope you're just doing a final concluding comment for us.
Yeah, it was. Yeah, the final concluding comment was just on the adults bit. Yes, I got the hint. It's just to say, yeah, completely agree with Mike. Although I will say there is a lot of collaboration underneath the boards that goes on between practitioners and managers across children and adults, and service, certainly at service director level. So, although the boards are constructs, you're correct, Mike. It's not the only area for collaboration.
Thank you. In order to conclude this, I must refer members to the recommendations on page 70 that we note the assurance report and its contents, and we're asked to note the joint agency priorities and highlight any particular contributions that the Safeguarding Partnership could make on the joint health and wellbeing strategy. And I think that's a piece of work going forward. Tom's absolutely right. We must give thanks to all the partner agencies involved in this board, and also, oh dear, it's because I'm not at another meeting, they're ringing me. And also thank Sheila for her work on this and driving it forward in partnership with Mike as well. If people are happy with that, I'm now going to announce that is the conclusion of this afternoon's meeting. Can I thank everybody who's attended, everybody who's contributed and presented to the meeting. It has been really, really interesting and effective today. Thank you very much.